So we've been saying a lot so far today about bipolar depression. Let me, in fact, if I can now enumerate what I would see as a quick calculus in my head, 5 principal therapeutic targets that we're asked to deal with on a day-to-day basis in bipolar disorder. We're asked to deal with subsyndromal depression and anxiety. And in the language of the research domain criteria, you'd call that positive and negative valence disturbances. So subsyndromal depression and anxiety is one therapeutic target. The second therapeutic target is something that Nasir spoke to, and that is temperamental affect or temperamental instability of thought, feeling, and behavior, which is not only, in fact, additionally labeled as personality disorder, but clearly as a burdensome, morbid part of the illness. Thirdly is chronobiology. Fourthly is cognition, both general and social cognition problems. And cognition is really, in fact, the obverse side of the coin of function. So when someone with bipolar disorder is not back to work, what they're really telling you is that my cognition is too big to fail, and it's failing. The gist of the slide, I call this the terrain setting slide, that we've got plenty of options for mania. Acute depression is relatively thin, and then maintenance is a bit of a mix of things, but clearly, at least numerically, quantitatively, we've got more treatment options. Let's shift directions. I just want to spend a brief moment on mania. I don't think we struggle with mania. Let's talk about depression. Let's talk about mixed. So patients, when surveyed, asked about their bipolar treatments. This was a survey I did in almost a dozen countries, asking a very simple question: what do you want from your bipolar treatments? And what emerges, what emanates, what surrounded this entire survey is they clearly want better treatments for depression and all things that you could link to depression, like anxiety and sleep and suicidality. And they clearly did not want to have impairment of function. We've historically given more emphasis to symptom reduction. Patients repeatedly give more emphasis to quality of life, burden of illness, function, and that certainly emerged from this survey. I would not give an antidepressant to someone with mixed features. I have, in fact, found, this wasn't a strategy, it wasn't an ideology, it wasn't a mission, but I have found that I prescribe monoamine oxidase inhibitors a lot in my program, not first or second line, but parinate, Nardil, meclobamide at 1,000, 1,200 to 1,400 milligrams daily is turning out to be a very sort of often prescribed treatment. There is the concern that tricyclics and MAO inhibitors, maybe SNRIs, may be more likely to destabilize bipolar patients. And I think that may be true. The evidence would certainly give us reason to believe that. And this is Mark's slide, which this was actually a very thoughtful way to look at this issue with an effort to identify, and Mark explained his study, and I'm not going to go through this again, that there clearly is a subpopulation who should not get these treatments. Because we want to know what treatment should people get and what people should not get what. And so mixed features patients should not be getting antidepressants. Rapid cyclers, not antidepressants. Antidepressant monotherapy is probably not a good idea in bipolar 1. Bipolar 2, I don't think we really know with the utmost of certainty, but I have found to this day I'm still not that comfortable with antidepressant monotherapy, out of the block at least, in BP2. And this really makes the case, I think, that a fairly low dose of activation is a clarion call for concern in patients who are exposed to antidepressants and bipolar. It was a very nice study. I've shown this a lot, Mark. It's been a nice study for the field. Aripiprazole was studied in bipolar depression, and there's replicated evidence of efficacy that did not work. Now, it didn't work. That's the bottom line. It works in major depressive disorder, did not work in bipolar depression. And there's been a whole industry of kind of, just like this political season in the United States, there's all these talking heads on TV. There's a lot of talking heads who have all kinds of ideas why studies work and why they don't work. And I think there's some legitimate sort of comment that maybe there were some method aspects around this study, but that's fine. That's all just talk. The fact is it didn't separate. And we have plenty of examples where treatments in major depressive disorder can provide a reproducible positive outcome. And yet bipolar disorder doesn't seem to produce, at least reproducibly, an outcome that we see in major depression. This was Latuda, derived, its progenitor molecule is an anxiolytic antidepressant. optimized to create an antipsychotic. It was studied in bipolar depression as adjunctive monotherapy. This is replicated with signal and effect size that would be a Cohen's benchmark that we think is clinically relevant. Between 0.3 and 0.5 is thought to be clinically relevant in the business of medicine. So this was a treatment that had that signal. I had approached the company with an expectation of no, but I had approached the company, said, let's in fact look at the data, because the majority of people that I see with bipolar depression have mixed features. Now, mixed features have been narrowly defined in BP disorder in DSM-5 to exclude symptoms like anxiety, agitation, irritability, indecision, insomnia. In other words, what the authors of DSM-5 attempted to do is, to the extent possible, is to have some level of specificity. They didn't want to count symptoms twice. And if you look at the polythetical list of MDE and mania, there are some symptoms that overlap. So if you're going to have a mixed features specifier that applies to either pole, you don't want to count symptoms twice. So I think very reasonably they said we're not going to include anxiety, agitation, indecision, insomnia, among others, distractibility, as features. And they tried to have this more specific approach. And if you look at that whole combination, that whole of features, the majority of patients with bipolar depression have one or more of those. This was an effort to answer two questions. What percentage of people with bipolar depression in the Latuda development program fulfilled the DSM-5 criteria for mixed features? The answer was 55%, majority. Second of two questions was, how does lurasidone perform in those with mixed features? And we took the Mark Fryan definition of what was a clinically relevant dose of mixed features. In other words, we chose a YMRS score of 4 or greater based on Mark's study. And we also chose a second definition. At the time, the DSM working group was kind of meandering back and forth. It could be 2 symptoms or 3 symptoms, 2 symptoms or 3 symptoms. It turned out to be 3 or more. At the time, they wasn't sure, so we went with 2 symptoms where the score was at least 4 or greater. Let's just look at, if we could, subsyndromal hypomania group 1. The message is that we actually saw a signal that was efficacious. So I'm often asked, does lurasidone treat mania? Lurasidone was never studied in mania. But we have post hoc evidence that it can treat the activation phenomenon that is so often, 55%, seen in those with depression. And this is the very group that is often pummeled with antidepressants, one after the other, with bad outcomes. And if they're not getting antidepressants, they're getting 3 benzodiazepines, and they're smoking weed. Okay? And so this is the group, and Mark's data would support this next statement, that should not be getting antidepressants, who have elevation. And I would take the view that atypical is preferred here. Now, Sanofian went forward, and they had reasons to believe that Latuda had an antidepressant effect, but also had an effect where it could mitigate these mixed features. And this was a study that was published recently with Tricia Supez from Stanford as the first author. And this was in major depressive disorder as monotherapy. And as monotherapy in MDD with mixed features, there was a signal that was indicative of efficacy, robust efficacy. Effect sizes of 0.8 is pretty high octane. And what's also important to underscore is that the hypomanic symptoms were not amplified, neither were the anxious symptoms. In fact, they were mitigated. And this benefit was seen very early on after just a week of treatment. And it reminds me of, in fact, the word ataraxia, which is a word, nowadays the residents are so ahistorical, they don't read anything in the history of psychiatry. But when the antipsychotics were being developed, the quest was for ataraxia, a certain quietude and a certain alleviation, a sort of solace of sorts, that distress, that tension, that turmoil. And these are patients who I think approximate that with some of the atypicals. I had started a study when AstraZeneca was promoting Seroquel. We had a study at 50 sites across Canada where we were going to compare quetiapine to venlafaxine in major depressive disorder with mixed features. And just when we got the protocol started, AZ lost their patent on Seroquel. They pulled all the money. We couldn't do the study. So it would be really cool to compare an atypical efficacious and MDD with mixed to an antidepressant. That would be a cool study. Because I think as psychiatrists, we struggle. Every psychiatrist knows that if you have a patient with major depressive episode as part of MDD, and that person has hypomanic symptoms, and you put them on an SSRI, you know they're not going to do very well. Most don't do very well. They have bad outcomes. They just don't respond. They have, in quote, side effects. They just don't do well with it because it activates them. That'd be kind of a cool study. The company went further into this. Alan Swann, many would know Alan Swann. I think he's really one of the more thoughtful thinkers. He's actually a thoughtful, cascades down into the granularity and thinks this through in terms of phenomenology. He's done a lot of so-called symptom structure analysis studies in bipolar. And whenever I think about dysphoric states or mixed states, I think about Alan's work. He's done so much in that area. He's down in Texas. He's the first author on this post hoc analysis, which was presented at APA in Atlanta. Now, this is, again, a bit more kind of slicing and dicing and cutting this up, but there's a concept here I think really, really important. You see lots of lines, too many lines, frankly. This is not a great slide, but too many lines. But here's the gist. The gist of this is, and I'm going to point it out over here. I can't even see it over here. Okay, it's over there. So right here, see that 1.41? 1.41? That is an enormous effect size. What is that referring to? That's referring to people with major depressive disorder and mixed features who have irritability. And irritability was operationalized in a way that they could define it based on the scale. These are people who had a lot of irritability. And they were able to show that, yes, this is a treatment in MDD with mixed. It does not amplify hypomania, and it's particularly robust in irritability. And I think this is a very common chief complaint that people have. If they don't have, there's certainly their family members have on their behalf for them. So we have this outcome. Now, I believe Nasir was involved in this study, if I recall correctly. This was a study in MDD. It was sort of a small study with MDD and bipolar 2. And ziprasidone, which hasn't really been studied as much in this area, showed some evidence of efficacy in mitigating the symptoms. In this case, it was the depressive symptoms as evidenced by change scores on the MADRS. So I don't think we know for sure if the observations that we just saw with lurasidone and MDD mixed are confined to lurasidone. I'm frankly skeptical it's confined to lurasidone. But I think we're going to have other atypicals that could possibly be effective in MDD mix, but that's just speculation. We have this was a randomized controlled trial in a small set of people with MDD and bipolar 2. But I think, step back 2 steps, I think atypicals provide evidence of efficacy in this particular phenotype. The deal breaker has been side effects, and within that category, it's been a combination of EPS, sedation somnolence, and it's been metabolic/anthropometric changes. And I don't think anyone's unaware of this in terms of the adverse event profile. I do find it curious to me as a clinician, as an academic, as an advocate of people with this illness, why the prescription data continues to indicate to us, and this is replicated, that people with bipolar disorder often get conventional antipsychotics, they often get antidepressant monotherapy, and they often get weight gain promoting drugs first line in treating this illness. That's always been curious to me why we've been so discordant with the patient-centric outcome literature, what they're looking for. Let's keep this very practical. Is there a role for anti-inflammatory agents in bipolar? We just published this. This was Josh Rosenblatt, one of my residents, led this campaign. And we looked at the extant literature, omega-3s, polyunsaturated fatty acids. We looked at TZD, thiazolidinediones, NSAIDs, N-acetylcysteine. People like a bottom line. The bottom line is that there is a signal. There's a signal, and you can see at the very bottom, that diamond just to the left at the bottom. But there's also an asterisk, and the asterisk is tremendous heterogeneity here in the type of studies that were done, the patients, the dosing, the outcome measures. And quite frankly, it's my read of this literature after we did this meta-analysis, I don't yet believe that these treatments are ready for the prime time. Now, what if you've tried everything and you're at the tertiary level of managing your patient? Is it a coherent, reasonable thing to consider in a patient? I would say yes, but that's way, 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 way downstream. These are not ready for prime time. And what we need is a more sort of focused approach. So we are developing an anti-cytokine, 2 of them in fact, to treat not bipolar, because bipolar is not a monolith. We're trying to treat a dimension, and that being cognition and anhedonia in these patients. I think it's the better way to go forward. I want to show you something else about what we're doing in my clinic, in my foundation, in the research space, but also in the clinic as something new for patients. So bipolar disorder is a brain disorder that has profound multi-organ involvement. And Mark had renewed our sort of familiarity with the global burden of disease study from the World Bank and so on. And we know that mortality in this population is significant. Last year, Ben Goldstein, good friend and colleague here in Toronto, Ben's a pediatric psychiatrist with an interest in bipolar. Ben and I and a group of cardiologists, pediatric cardiologists, got together and we published a position statement on behalf of the American Heart Association wherein bipolar is a tier 2 risk factor for cardiovascular disease. And I've had an interest in this area for a long time because I was always curious, why do bipolar patients who have obesity and diabetes, why are they so cognitively impaired? More so than the bipolar patient who's not overweight or diabetic. And that's been a question that's been in my mind for better part of 20 years. And there's a whole story around this now. We now know that obesity does metastasize to the brain. And we know that the brain is changing in response to chronic exposure to metabolic alterations. Let me just do an informal survey right now. I want to ask you a question. So I have noticed, in my experience in the last 20 years as a psychiatrist, 16 years I've been a psychiatrist, I have noticed in that time that I see fewer and fewer euphoric, laughing, infectiously funny, giddy, bipolar patients, life of the party patients, and I see irritability, anger, hostility, and nastiness. That's what I see most. That's with my patients, not my family life or my staff, okay? So my question to you is, by show of hands, who sees less euphoria and more dysphoria in the last 10, 15 years? Yeah. Every psychiatrist I've asked this question to in Africa, Asia, Australia, the Americas, say the same thing. Now, it could be the case that this is just a function of the healthcare system. It's more difficult to get to a psychiatrist. I don't believe that. But you have to have a set of hypotheses. And I'm not sold on that. Mark did some nice work years ago looking at polytherapy increasing in bipolar, seeing sicker patients in tertiary centers. Could it be that the dysphoria that we're seeing more of in patients is a function of antidepressant utilization? Possible. Is it due to the use of illicit drugs like crack and cocaine? Possible. Let me now add one thing onto the list, which I'm now wondering is playing a role in this. Is the obesity epidemic changing the phenomenology of bipolar disorder? I don't know. But what we do know is that obesity in bipolar disorder changes the brain. And it changes the brain circuits in such a way that the normal segregation and integration is abnormal. The reciprocity is abnormal. Consequently, they have more negative valence problems. They have more depression, anxiety, arousal, more cognitive disturbance. And cognitive disturbance is the lesion that leads to mixity. And so this is not a theory, that's a fact. But stitching it all together is more theoretical. And I've wondered whether the obesity epidemic is changing the phenomenology of bipolar. We know it gravitationally pulls them downward cognitively and certainly takes away their CEO control over their affect regulation. This is some work by Kang Sim, a very good friend of mine in Singapore. Singapore is a very impressive city-state, gives tremendous priority to the human capital of their population. They fund research, it's unbelievable. And so we did a study in bipolar patients looking at brain circuits as a function of obesity. And what we found was obese bipolar patients had a very different brain circuitry. In other words, the efficiency of the circuit, we can measure it with what's called tractography, was different. And again, we're trying to find the substrate that subserves this, not just for academic purposes, but can we then modify this? If this is true, if this is actually, affecting disease processes, then maybe we can target these systems. So that was the thought we had in mind. So liraglutide is Victoza. It's an anti-diabetic drug. And I prescribe this drug a lot with my bipolar patients. Well, not because they have diabetes. I prescribe it for their bipolar illness. Now, that's off-label. It's investigational. But I want to just give you a kind of walk through this. Victoza is a drug approved for diabetes and weight loss. It's an incretin that targets the GLP-1 system. Now, glucagon-like peptide is located in your gut, but it's also produced in your brain, in the nucleus tractus solitarius. And it's densely populating the cognition control center in the brain. So what we did is we started off in rats. Dr. Li Gu, who's a psychiatrist with a preclinical capability, who works with my foundation, ran liraglutide in animals, showing that this anti-diabetic weight loss drug would increase brain-derived neurotrophic factor, would increase spine density in the neurons, and would also increase another protein which has become kind of a new kid on the block called mammalian target of rapamycin, mTOR. And while we were doing that, contemporaneously, we ran this study in bipolar patients. We gave them liraglutide, they're not diabetic, which we've been using to help their cognition and reduce their depression, 1.8 milligrams a day. It's a needle, and they get weight loss with it. They like that. And Mark educated us on what the NAA was, and we saw improvements in the ratio using MRS technology of NAA to creatine, and we saw an improvement in their cognition measures. So where I'm going with this is that, remember I started off by saying that there's only about not even quite half a dozen targets: depression, subsyndromal depression, affective instability, cognition, chronobiological changes, and comorbidity. This treatment is a domain-specific treatment. This treatment targets cognition. This treatment targets their difficulties with positive valence because it has an anti-anhedonia effect. And one of the reasons I've liked using MAO inhibitors for so long is because I think they're very good for anhedonia. This treatment targets the reward center in the human brain. It's being now developed for substance misuse problems. So this is in fact now the current recommendation in this Medicaid system, that the first-line therapy, quetiapine or lurasidone monotherapy, lurasidone adjunct or monotherapy, is the first-line strategy. There's 2 points I want to make. One is that quetiapine is the only agent with bipolar II depression. That's why it's in there largely, but it does have obviously metabolic limitations and sedation. But what I really want to underscore is that olanzapine has been demoted to second line. And what was interesting, this guideline process, and I've been very privileged to have been invited to be part of this, and I've led the MDD guidelines, which are going to be published later on this year in the Journal of Clinical Psychiatry, is that around the table was about 50 people. I've never done this before, because usually when we create guidelines, it's just a group of academics who just kind of get together and exchange ideas and thoughts. This was actually comprised of advocacy, health economists, policy people, politicians, healthcare administrators, clinicians, and a few academics like me at the table. And this demotion of weight gain promotion drugs was driven by the health economy people, health economics people, and because of the cost and so on and so on. It's unfortunate that money had to, in fact, make this change, but anyways. So we have, in fact, lithium and lamotrigine as next on the list, and I agree with Mark's meta-analysis that he showed around lamotrigine. And you all know lithium's anti-amyloid effect, anti-herpes simplex virus, anti-suicide effects. Here's ECT, and then after that, it gets into kind of a sundry strategy list with different antidepressants and on that particular list there. Now, I want to shift directions. My last slide, I'm going to finish with this one. This is major depressive disorder with mixed features. And I wanted to, so Kreplin is smiling in his grave. Because first of all, well, he's not smiling, he's probably irritated. He wasn't a co-author on the DSM-5, he should have been. But he's smiling because the Kreplinian dimensional approach, which I think is more orthogonal, is now been instantiated in the way DSM's codified mixed features. And every experienced psychiatrist knows that a patient with a major depressive episode, but no past history of hypomania or mania, who's in your office with activation symptoms, which today we call mixed features, back in 1979 would have been called maybe in part agitated depression, you know when you put them on an SSRI, you're not going to see a sufficient outcome. And so then what does the evidence say? We have very little evidence. We have the one study with lorazepam. We have a smaller study with ziprasidone. Lots of clinical experience and lots of case reports and case series. A colleague, Mario Maj from Europe, Italy specifically, has published a lot in this area. So we had a choice. Give people no direction and just say there's no evidence and have a blank screen, or provide some pragmatic advice. And the guiding principle of these guidelines is to provide some advice to primary care. And I'm just going to highlight just one line here, that antidepressants are certainly considered as first-line agents, but look what's here. Mood stabilization agents is a possible first-line strategy for MDD with mixed features. So I'm going to stop there. Thank you very much.